Welcome, colleagues. Today, we're diving deep into one of the most demanding areas of our practice, managing the complex trauma patient. You know, this is where our skills in physiology, pharmacology, and crisis management are put to the ultimate test, often all at once and under incredible pressure. And this quote just hits the nail on the head. This is the fundamental conflict we face. It's a physiological tightrope walk where the textbook treatment for one lethal problem is the absolute worst thing you can do for the other. Our decisions in these moments aren't just critical, they're made in a matter of seconds. So that's the big question, isn't it? When everything you need to do is a contradiction, how do you chart a course? Well, that's exactly what we're going to tackle. This explainer is all about providing a clear framework, a roadmap, to help us navigate this high-stakes environment and bring order from chaos. All right, here's our game plan. We'll start with the golden hour and the initial assessment. Then we'll cover securing the airway, which is our territory. We'll move on to the modern philosophy of damage control, protecting the brain, managing other systemic injuries, and then we'll tie it all together with a case study. You've all heard of the golden hour. It's that critical window where our actions have the greatest impact on survival. And the tool we use to impose order on that chaos is ATLS, Advanced Trauma Life Support. Think of it as the universal language of the trauma bay. It's not just some checklist, it's a disciplined mindset that forces us to tackle the biggest threats to life first. So let's look at this table. The real beauty of ATLS is its relentless logic. A before B before C. Why? Because a patient without an airway is dead in 3 minutes. A patient who isn't breathing is dead in 5. Everything else can wait. But here's the key. This isn't a slow, step-by-step process. It's a dynamic dance. While we're assessing circulation, someone is already getting IV access. As we're checking disability, the blood is being hung. It all happens at once. Now for the D in our ABCs, disability. The GCS is our go-to tool. It's a quick, dirty, and incredibly effective snapshot of how bad the brain injury might be. And for us, it has a very clear implication. You know the old saying, GCS less than 8, intubate. It's a strong signal that the patient can't protect their own airway and needs definitive control right now. It's simple, it's fast, and everyone on the team understands what it means. All right, let's move into our primary domain, the airway. This isn't your routine elective case. We're dealing with a physiologically unstable patient who we have to assume has a full stomach and a potential C-spine injury. The pressure is immense, and our margin for error is basically zero. And this is where the trauma airway algorithm differs fundamentally from the elective one. Once we push those induction drugs, there is no turning back. We can't just wake the patient up if we get into trouble. We are committed. That's why step 1 is to prepare for failure. The surgical airway kit needs to be open and ready, not in a cabinet down the hall. If RSI fails, we try to oxygenate. But if we hit that dreaded can't intubate, can't oxygenate scenario, we can't hesitate. We have to go to the surgical airway. Delay is deadly. So what drugs are we using? Our choice of induction agent is absolutely critical. In a hypovolemic patient, propofol can be a disaster. It's a potent vasodilator and cardiac depressant that can send their blood pressure into the basement. So we lean on etomidate and ketamine. Ketamine, in particular, is a fantastic choice. It supports the blood pressure, which in turn supports cerebral perfusion. And that old concern about raising intracranial pressure, it's largely been dismissed, especially when you weigh it against the catastrophe of hypotension in a brain-injured patient. Next up, neuromuscular blockers. This is the classic debate, succinylcholine versus rocuronium. Sux is undeniably the fastest, giving you perfect intubating conditions in under a minute. But it comes with risks. High-dose rocuronium, on the other hand, is almost as fast, and the arrival of Sugamidex has been a total game-changer. The ability to fully reverse a profound block in minutes gives us an incredible safety net that we just didn't have before. Okay, let's shift gears to circulation. And here, we've seen a massive paradigm shift in the last couple of decades. The old way of thinking was pour in the crystalloid. We dump liters of saline into patients to chase a normal blood pressure. We now know that was actually harming them. It was diluting their clotting factors, making them cold and acidotic, literally fueling the fire of the lethal triad. The modern approach isn't about volume, it's about function. This table lays out the new strategy perfectly. Think of it in phases. Phase 1 is pure survival mode. The patient is actively bleeding out. Our goal is damage control. We accept a lower blood pressure, permissive hypotension, and we give blood products in a balanced 1:1:1 ratio. Once the surgeons get control of the bleeding, we move to phase 2. Now we can be more precise. We use tools like ROTEM or TEG to guide exactly which products the patient needs.
Then, finally, in phase 3, we work on restoring everything back to normal. And to understand why we do this, you have to understand acute traumatic coagulopathy, or ATC. This is so important. This isn't just us watering down the clotting factors with IV fluid. This is an active process. The body's own shock state and tissue damage trigger a massive anti-clotting and clot-busting cascade. It starts the second the injury happens. That's why giving plasma and platelets early isn't just replacement, it's active treatment. So, damage control resuscitation, or DCR, is our weapon against that lethal triad. We let the blood pressure ride a little lower to avoid blowing off newly formed clots. And this is a huge caveat we're about to get to, that does not apply to patients with a traumatic brain injury. We replace what's lost, blood, with what's lost, blood components. We strictly limit crystalloids, and we give TXA early to shut down that hyperfibrinolysis we talked about. So while we're fighting that battle against hemorrhage, we have to simultaneously protect our most precious asset, the central nervous system. And this is where the central conflict of trauma resuscitation really comes into focus, because the rules for managing the brain are often the exact opposite of the rules for managing bleeding. Look at this list. The number one goal is avoid hypotension. A single systolic reading below 90 can double the patient's mortality. That is a staggering statistic. We can't reverse the primary injury from the impact, but we absolutely can prevent the secondary injury from ischemia and hypoxia. And that means every decision we make, every fluid bolus, every vasopressor, every ventilator setting has to be viewed through the lens of protecting that brain and maintaining its perfusion. Of course, trauma patients rarely come with just one or two neat problems. They're often a constellation of injuries, a whole body assault, and we have to be ready to anticipate and manage all of it. And each of these brings its own anesthetic challenge. You start positive pressure ventilation and the patient suddenly crashes? You better be thinking tension pneumothorax. That pelvic fracture? It's a massive reservoir that can hide liters of blood. We have to have a high index of suspicion and be constantly reevaluating, because any one of these can become the new number one threat to the patient's life at any moment. Okay, so we've covered a lot of theory. Now let's bring it all together and apply it to a real-world case. This is where the rubber meets the road, where we have to manage all these conflicting goals in real time. And here is our dilemma, laid out in black and white. The brain is screaming for more pressure to stay perfused. The bleeding belly is begging us to keep the pressure low to allow clots to form. So, who wins? The answer comes down to one question. Which injury is irreversible? You can always take a patient back to the OR to wash out a clot and repack an abdomen. You can never undo an ischemic brain injury. The brain wins. The brain has to win. So let's watch how this plays out. Patient hits the door, GCS 6, BP is 85/50. The decision is made instantly. We are not doing permissive hypotension. We activate the massive transfusion protocol to bring the pressure up with hemostatic products. We get them to the OR for damage control surgery, pack the abdomen, stop the bleeding. It's only after that, in the relative calm of the ICU, that we can fine-tune our approach with ICP monitors and viscoelastic testing, all while continuing to focus on neuroprotection. So if you remember nothing else, remember these 4 things. 1. Prioritize the irreversible injury. Protect the brain. 2. Use ATLS to bring order to chaos. 3. Embrace the damage control philosophy. Save the life now, fix the parts later. And 4, remember that we as anesthesiologists are the leaders of the resuscitation. We are the conductors of this very complex orchestra. I'll leave you with this final thought. In an age of advanced monitors, sophisticated lab tests, and detailed algorithms, what is our single most important tool? It's our clinical judgment. It's the ability to take in all of this conflicting data, understand the competing priorities, and make a decisive, reasoned choice for the unique patient right in front of us. That's what makes the difference. Thank you.